let's talk about a subcoracoid impingement. So what is a subcoracoid impingement? Subcoracoid impingement is impingement of the subscapularis tendon between the coracoid and the lesser tuberosity of the humerus. So before understanding the definition of subcoracoid impingement, we must understand the anatomy of the rotator cuff and the relation of the coracoid into the lesser tuberosity as well. So let's look into the rotator cuff itself. So rotator cuff, as we know, has 4 tendons. The front is the subscapularis, supraspinatus at the top, infraspinatus and teres minor at the top and the back. So in this subcoracoid impingement, the muscle which is getting impinged is the subscapularis tendon. So the anatomy of the subscapularis tendon is also very important. The subscapularis muscle originates from the front of the scapula and it inserts into the lesser tuberosity. So when it travels from scapula to the lesser tuberosity at the level of the glenohumeral joint, the coracoid, which is a lateral process of the scapula, it can impinge on the subscapularis tendon. The impingement mainly occurs in actions which requires adduction, internal rotation and flexion of the arm. So let's look into the what causes subcoracoid impingement. The mainly 2 causes. The first and foremost is having a abnormally long coracoid process, or the second one, if you have a tightness in the posterior capsule, or if you have a loss of internal rotation, that can put undue stress in the front of your shoulder. At times it can be associated with subscapularis tears, supraspinatus tears and infraspinatus tears as well. So how will you identify a patient with subcoracoid impingement in the clinic? So you must understand the symptoms of subcoracoid impingement may sometime overlap with subacromial impingement as well, and some patients may have subcoracoid as well as subacromial impingement as well. So some people may have pure subcoracoid impingement. So let's, for example, a pure subcoracoid impingement patients may report pain in the shoulder, mainly on the anterior aspect of the shoulder, and they can report that reaching out to object like this or a pushing which requires flexion, adduction, internal rotation can be painful. In clinical examination, you should look for tenderness mainly on the anterior aspect or the coracoid process, and also you should be able to reproduce pain on flexion, adduction and internal rotation of the arm, mainly in this movement. You ask, flex, internal rotate and adduct, and if this causes intense pain in the front, that's possibly a subcoracoid impingement sign. Then once you suspect a patient is having subcoracoid impingement, you must make sure that they don't have other pathologies, and also to confirm that they have subcoracoid impingement, you must perform certain investigations. You start with X-rays, you look for the coracoid profile in an outlet view, and further testing is required. Ultrasound scan is very useful. We can assess the cuff integrity, mainly the subscapularis tendon integrity, and at times it can be coupled with therapeutic or diagnostic injection as well. CT scans are useful. CT scan, we need to look for the distance between the humeral head and the coracoid. The distance between the humeral head and coracoid, if you look at the CT scan in a normal position, it's around 8.7 millimeter. If you adduct or if you cross your arms and then take a CT scan, the distance becomes less. In a normal person, it will be around 6.7 millimeter. If it is less than 6 millimeter, that's considered as abnormal. CT scan is not commonly used, but it's for academic interest. MRI scan certainly is useful, mainly to identify cuff tears and to also comment on the distance between the humeral head and the coracoid, mainly in the axial views. So certainly you have quite a few options. You can start with X-ray and then perform an ultrasound scan, and if you're still not conclusive, then perform an MRI scan. Okay. So once you have diagnosed a patient with subcoracoid impingement, how to treat them? Certainly, you start with non-operative measures. You start with asking the patient to rest the shoulder, avoid the activities that will increase the pain, take anti-inflammatory medication. You can request for an ultrasound guided injection for the subcoracoid space. This can be a therapeutic as well as diagnostic, because if the patient has a pain relief, that indicates that that's the area of problem. And then if the patient has no pain relief for a long period, and if has any recurrence, then you can plan for appropriate surgery. Physiotherapy has a role. You can refer the patient for stretching exercises, mainly if there is any lack of internal rotation or a tightness of the posterior capsule. So for example, if we've already tried all these conservative measures, what should we do next if the patient comes back with again pain on the anterior aspect? So then certainly you have to look for surgical treatment options. Surgical treatment options can be either open surgery or arthroscopic surgery. Nowadays, most of the surgeons are resorting for arthroscopic surgery, but the principles of both arthroscopic and open surgery are same. The aim is to create the distance or a space between the coracoid and the humeral head, so that the subscapularis has more room for when you have movement of internal rotation, adduction and flexion. So in the term of this operation is called either open or arthroscopic coracoplasty. You tell the patient that if you are having an arthroscopic surgery, you should preempt that they may have a problem with subscapularis tendon. So they should warn the patient that they may have a subscapularis tendon repair as well. So in the surgery, you basically perform a diagnostic arthroscopy, identify the coracoid and shave away the posterior lateral corner of the coracoid so that you have enough room for the subscapularis tendon to move freely. You can test it dynamically, even in while performing an arthroscope. You can put the arm in a position of adduction, flexion and internal rotation and assess how much clearance have you got after the coracoplasty. As I mentioned, open surgery is an option which has been done in the past. Even there, you detach the conjoint tendon, take away the part of the coracoid which will be causing impingement, and then reattach the conjoint tendon. But open surgery is rarely performed, as because everybody is confident in using arthroscope nowadays. So in summary, subcoracoid impingement is impingement of the subscapularis tendon between the coracoid and the lesser tuberosity of the humerus. Having a long coracoid process is a predisposing factor for development of this problem. Patients often complain of pain in the anterior aspect of the shoulder. Pain is provoked by position of flexion, adduction and internal rotation of the shoulder. X-rays are useful in identifying the profile of the coracoid. Ultrasound is useful for diagnosing subscapularis tear. MRI scan is useful, mainly the axial images can identify the space between the coracoid and the humeral head. Treatment, of course, is non-operative and operative. Non-operative will have rest, activity modification, anti-inflammatory steroids and physiotherapy. Surgery, either open or arthroscopic coracoplasty plus or minus subscapularis repair.
We hope you liked this tutorial. Please subscribe to our channel for many more videos. Feel free to leave any comments below, including requests for any new topics. You can visit us on www.orthotutor.org and www.GoMedic.org. Thanks for watching.